Hello folks, today we will talk about the anatomy of the face. Okay, facial anatomy. So now this is not about the total head, but only about what is about 1 finger's thickness under the skin. For the total anatomy of the head, I must refer you to the special lectures and courses in anatomy. There are a lot of good textbooks on this topic, and ultimately you can find all the contents I address in this lecture, of course, all the pictures and words in our atlas, The Face, and in my textbook, Oral Structure and Biology, which is why I always include the page numbers on the top left-hand corner. More anatomy of the whole head can be found in the Universal Atlas of Anatomy, and on the far right side there is my book about the face for everybody. It has a real mirror on its cover and not yet translated into English, although it is available in Mongolian language because one of my graduate students was from Mongolia and she is now leader of a clinic in Ulaanbaatar. She, Niamdori Tsinkel-Saikan, has translated the book in Mongolian language and she said it's a bestseller there. No matter who you look at, here we see the former chancellors of the Federal Republic of Germany. All the faces look so different that we can recognize who is who. That is also why there are pictures in the passport, and yet the anatomy of the face is basically the same for every person. There are only very rare individual deviations from the basic pattern. The face is also somehow very special. Our face is not covered by clothes, but for your body, you choose beautiful stuff to dress in the morning and you stand in the bathroom for a long time in front of the mirror and you ask yourself, can you go out on the street with this face that is looking at me from the mirror? And now we are going to study this anatomy in detail. It's going to be a very long lecture and I'll give you an overview, and if you will, these are the learning objectives. First, we'll look at how the face is divided into its typical regions, and then we will talk about the skin and what happens there when the skin as we get older. And under the skin, we find more or less fat and the muscles of the facial expression run partially embedded in it. And then there will be a larger section about each muscle of the face and how it relates spatially to the other structures. We will do this layer by layer, and this procedure is also called topographic anatomy. In contrast, there is the so-called systematic anatomy, where the anatomy is discussed again in a different way, like this. Which are the muscles of facial expression in contrast to the typical chewing muscles? And what is the fundamental difference in the innervation? Some muscles are reached by the facial nerve, others from the trigeminal nerve. How is it with the motor innervation in contrast to the sensitive and sensoric innervation, and so on? And in this lecture, I will only marginally deal with such kind of questions. Here, as an introduction, I will deal with the whole picture before you get into the details and the systematics. I will also give you hints on what to expect with the vascular supply. However, the individual names of the vessels and their branches are rather boring for a lecture. You will have to read that in the book at your leisure time. And yes, you will have to learn it by heart sometime also. The same applies to the innervation. And then, because we are working ourselves down layer by layer, we will have arrived at the skull. And as I said, our focus here is on the topographic anatomy, layer by layer. And before I forget, the temporomandibular joint does have its own lecture. It is so special and it would go beyond the scope here. So let us start with the regions of the face first. Let's say you need to write a doctor's letter or discuss a particular finding you've seen with some colleagues. You need to be able to describe where you saw it. And this is one of the reasons why we should be able to distinguish different regions of the face. But there are also anatomical reasons because of structural differences. So let us start with the forehead. That is the frontal region. And next to it, there is the temporal region. And the eye has its own region called the orbital region, as does the nose, which is called the nasal region. Below that, the mouth in the oral region, and the chin below that, the mental region. Anatomically, the cheek, the buccal region, is relatively small because there you still can subdivide special neighboring regions. The orbital region under the eye, and the zygomatic region and the parotideo-mesenteric region. This is where the prominent masseter muscle is located and the parotid gland. And the neck is divided into the omotracheal triangle. Here I have drawn the right and the left together, and next to it the regiosternocleidomastoid, and on the right side still the lateral cervical region. You guessed it, the skin is also of different thickness in these regions. So on the forehead and on the chin, the skin is the thickest, about 2.3 or 2.5 millimeters. It is thinnest in the orbital region and under the eye, and at the root of the nose, only 0.5 or even 0.6 millimeters thick. And in the other regions of the face, the values are somewhere in between. Now let us take a quick look at the structure of the skin. The outermost layer is the epidermis. It consists of a squamous epithelium that becomes increasingly keratinized towards the surface. And in the deepest layer, there are the stem cells that constantly renew the skin. And details will be given later in the lecture on the oral mucosa. The principle is similar there. And underneath there is the dermis. It consists mainly of collagen connective tissue. This makes the skin more or less elastic on one hand and also quite tough and tear resistant on the other. In this layer there are the blood and lymph vessels and nerve and glands. And still underneath there is a layer known as the subcutis. And here we find mainly loose connective tissue with deposits of fat. What else is inside the skin? Some hairs stick out at the top. They are formed in the hair shaft, which reaches down to the subcutis with its tip, the hair follicle. And next to the hair shaft are the sebaceous glands, whose secretion lubricates the skin and the hair. And then there are the sweat glands, which everybody knows. They are located in the subcutis and then, of course, have an excretory duct to the skin surface. The innervation of the skin varies from body region to body region. On the back, it is less densely innervated than on the face or elsewhere, you know. That means the nerve density is different. But everywhere, there are even free nerve endings and Merkel cells in the epidermis, plus some Meissner's tactile corpuscles. Both are mechanoreceptors. And you can see the finely intertwined blood vessels branching off from the somewhat thicker subcutaneous arteries and veins. Yes, and you can see it on the face. The skin ages. It becomes flabby over the years and follows gravity along with the subcutaneous tissues. In addition, the skin also continues to grow. Because we use the muscles of facial expression every day, there are also wrinkles in the same places all the time, which when you are young go away and when you relax. But the older you get, the more likely they are to stay and notch themselves deeper and deeper. In detail, it's a very complex procedure. There is the intrinsic aging of the skin, which describes the biological changes, a weakening of the metabolism, such as the decrease in the rate of cell division, decrease in cell turgor, which is the fluid content of each cell, age involution of the sweat glands and the sebaceous glands, and so on. There's not much that you can do about it. And then there is the extrinsic aging. First of all, the exposure to UV light, that's the sun. This increases the activity of enzymes that promote fragmentation of collagen fibers. So here we can do something about this. We should protect ourselves more against the sun and against any other harmful external influences anyway. Whether facial treatments with a lot of collagen or hyaluron really help a bit depends on how deeply they really penetrate the skin and whether they really change the metabolism there. In any case, those who have laughed a lot during their life, you can see it in old age by the course of the wrinkles on the face. And other people who are rather sad, in their faces the wrinkles run in a different way. So you can tell a whole life's history from the face. So now let us have a look at the activity of the muscles of facial expression. You can try that out in the mirror at your own convenience. Pull all kinds of facial expressions like here. Laugh, make your mouth pointed or look disgusted. What you observe are the corresponding movements of the skin. And if you do it intensively, you will also see wrinkles. These also ultimately serve the purpose of communication. Have you noticed that the wrinkles are always exactly perpendicular to the fibers of the muscle bellies? So when you laugh, you pull your cheek back and up at the angle. And this creates the thick nasolabial fold. And at the edge of the eye, you can see these small wrinkles called crow's feet. Running perpendicular to these wrinkles is the orbitalis oculi muscle. The orbitalis oculi muscle, which contracts when you laugh and thus wrinkles the skin. And if you pucker your mouth, you contract the orbicularis oris muscle, and you will see a lot of star-like radiating wrinkles, especially on the upper lip. In old age, these will remain visible even if you no longer pucker your mouth. And the more often you look disgusted, the more you see corresponding wrinkles on your face. Now we've come to the point where we can go more into anatomical details. However, as I said earlier, this lecture can only give a first impression on the anatomy of the face. If I were to systematically give all the information about the origin, insertion, course and innervation and function of each muscle, it would be a very tiring thing in a lecture. And in addition, the information in the illustrations would become too confusing. So in this lecture, I can only give an introduction. To really understand facial anatomy, you need to sit down and really study with the atlas and maybe have a skull model in your right at hand. And this would then be the best preparation and follow-up for the dissection course on the real cadaver. But let us start with a quick run-through, level by level, which takes exactly 60 seconds of duration. So after this quick tour, let us go through the most important details again, layer by layer. The entire face is coated by subcutaneous fat. The thickness varies from region to region and from individual to individual. However, the thin layer of connective tissue over the orbicularis oculi muscle often does not contain any fat, or only very little fat. The fat is embedded in a spatially extending honeycomb-like connective tissue network with many small pockets or fat compartments. They are stretched out in a space between the skin and from the inside and the most superficial muscles layer. It is called the superficial musculoeponeurotic system, abbreviated SMAS. This SMAS provides the connection between the skin and the muscles underneath. And that's why the muscles can move the skin. And that's what we perceive as facial expressions. In addition, you can also always find more or less fat embedded in the depth between the muscles. It is even possible to find individual larger fat compartments on a regular basis. These are shown here schematically in colors in the frontal view, and here again in the view from the side. These fat compartments can be individually filled with fat to varying degrees, which additionally gives a face a typical appearance in old ages. This then looks, in principle, similar to a bulging down jacket with the quilted seams, so just for understanding. And whoever still thinks that a facelift would be a quite simple procedure, just like you only have to pull the skin towards backwards in front to the ears, you will be surprised how the face then would appear. The anatomical conditions require a much more sophisticated surgical technique if you want to do it at all. Now we have removed all the fat here and we are looking at what is now visible. First of all, here is the parotid gland. This is the largest salivary gland. Oh, and before we go on, I would like to mention something. The illustrations that Karl Wesker has painted here in such an incredibly realistic way were really made after the living. We took hundreds of MRI images of my daughter Jana's head for several days, level by level and criss and cross. And these images then served as templates for us to create the atlas. And Jana was then able to study the anatomy of the face on her own face when she majored in medicine herself. I just wanted to mention that. So, and now we go on. Here the parotid gland. There may be additional glandular tissue, which is then called the accessory parotid gland. In any case, all the glandular secretion is collected and directed into the mouth through the excretory duct called the parotid duct. For this purpose, the excretory duct runs forward on the muscle and at an edge it sharply bends towards the oral cavity, passes through the buccinator muscle and can then be seen in the mouth on the inner cheek opposite to the first molar in the upper jaw. And now let's take a look at the muscles. First of all, the large forehead muscle. This is the occipitofrontalis muscle, here the anterior belly on the forehead. This muscle sits tightly on the skull like a cap and connected to the gallia aponeurotica, which we will see in a moment, does pull all the way back. And in the neck, this is then the occipitofrontalis muscle, which is called the posterior belly. However, it is not all muscle in the system, but between the two flat muscle parts just shown, the gallia aponeurotica stretches out. And this is the rough fibromuscular hood, or rather also called head fascia, which sits tightly on the skull like a cap. And it is mobile. If you tense the two muscle parts, the frontal and the posterior bellies of this occipitofrontalis muscle, then the entire skull skin would wobble back and forth, including the hair. And if the muscles are over tight, one can suffer from significant headaches. So on the side of the skull, above the ear, runs the superior auricularis muscle. It sits on the lateral portion of the gallia aponeurotica and pulls toward the perichondrium of the outer ear. You can try to see if you can tense this muscle when you wriggle your ears. Not everyone is able to do this. The fibers of this muscle fan up like this, and you can anatomically recognize other parts which have been given own names. Anteriorly, there is the temporoparietal muscle, and before that the even smaller anterior auricularis muscle, and in the back the corresponding posterior auricularis muscle. And that's how it is in anatomy. This fanned out muscle, which pulls from the head fascia to the side of the auricle, has 4 parts and thus also 4 names. And because you can tell them all apart, you have to learn them all. But it may also be that you don't always find all the parts in a specific patient, and it remains to be seen if these muscles are really that important. From the outside, the eye is covered by the orbicularis oculi muscle. This ring muscle is quite flat and lies on the eye, with its edges protruding beyond the bony orbit. In the middle of the course, this muscle has a horizontal slit, and this is where the upper eyelid and the lower eyelid do a join. This muscle is connected to the facial skin via the thin subcutaneous musculoepineuritic system, the SMAS, and can then pinch the skin over the eye and somewhat around it. You probably all know this one. That's the procerus muscle. So if you didn't know its name yet, you have probably drawn your eyebrows together X times in your life, like this. This muscle sits on the root of the nose, originates from the fascia above the nasal bone, and pulls upwards the facial skin between the eyebrows. In doing so, its muscle fibers pass through the anterior belly of the occipital frontalis muscle. It is not always easy to disentangle the individual fibers. In any case, when the procerus muscle contracts, you will see a vertical fold between your 2 eyebrows. Here is the nasalis muscle. It is very thin, and its fibers run from the maxillary bone to the side of the nose, very flat, on the bridge of the nose, and can also connect with the fibers of the procerus muscle. In some people, it also manages to pull up the sides of the nostrils a bit. The muscles on the nose are quite small. Here is the alaris nasi, sometimes also called alar nasalis muscle, or just called alaris. In any case, it lies very thinly on the cartilaginous nostril, and slightly medially, more toward the tip of the nose, lies just as small as the dilator naris anterior muscle, which, as its name implies, can dilate the nostrils somewhat when it contracts. And even smaller, even further towards the tip of the nose, we find the compressor narium minor muscle, which is supposed to contract the nostrils. Just as long as its name is its course, this levator labii superioris eloquenasi muscle runs from the forehead and down to the side of the nose into the upper lip. And it makes sense. When this long muscle contracts, it can pull the upper lip up. And as the name implies, if its muscle fibers also make contact with the nostrils, it can also pull those up with it. Now, we go a little further into the lateral region, and here is the zygomaticus minor muscle. It comes from the zygomatic arch and pulls on the upper lip. A little further laterally, the zygomaticus major muscle has a similar course. This muscle is slightly larger and attaches more laterally in the upper lip, more at the corner of the mouth. These 2 muscles, the zygomaticus minor and the zygomaticus major, run somewhat obliquely. And now, the risorius muscle runs fairly horizontally. It also pulls into the corner of the mouth somewhat more caudally from the zygomaticus major muscle. This muscle originates from the fascia of on top of the masseter muscle. All 3, this risorius and the 2 zygomatic muscles, they pull the lip and the corner of the mouth backwards. They are therefore active during laughter, and that's why the risorius is called like this. Now, here is the opposite of laughter. The depressor anguli oris muscle pulls the corner of the mouth downwards. It comes from the edge of the lower jaw and pulls toward the corner of the mouth. A little further medially, there is also the depressor labii inferioris muscle, which also arises from the edge of the lower jaw and thus pulls the lip downwards also. And of course, the upper lip can also be pulled upwards. This is done by the levator labii superioris, which has its origin under the eye at the upper jaw and at the zygomatic bone, and it pulls into the upper lip, where its fibers also mix with the orbicularis oris muscle. And there is the mentalis muscle on the chin. It comes from the front edge of the lower jaw and pulls into the skin on the chin. When it contracts, this chin gets a cobblestone-like wrinkling. And the platysma also belongs to the uppermost muscle layer. This is a thin skin muscle that in humans is found only on the neck and on the lower half of the face. In mammals, such a muscle can be distributed over the entire body. It is then called the panniculus carnosus muscle. Horses, for example, can twitch their skin almost everywhere on the body and to make the flies hop away. We humans cannot even make our necks twitch. Well, I can't do that. Now we go one layer deeper into the facial musculature. Once we have removed the platysma, then we can see the masseter muscle. This muscle is an important masticatory muscle. It extends from the edge of the mandible obliquely upward to the zygomatic arch. It has at least two portions called the superficial and the underlying deep portion. The deeper portion runs somewhat more upright with its fibers. There are supposed to be even more parts, which I think is quite possible. There is also a muscle with a similar course, but on the inner side of the mandible. This is the medial pterygoid muscle. This one and the masseter, they form a muscle loop with which we can press the lower jaw so firmly against the upper against the upper teeth, that there may result chewing forces of 400 kilograms, that is 4,000 newtons. That has been measured in humans. And partly covered by the masseter, we see the buccinator muscle. Its muscle fibers connect with those of the orbicularis oris. You can also say that both muscles, the buccinator and the orbicularis oris, are actually one continuous muscle loop, which, starting from the pharyngeal wall and pulling forward through the cheek, that confines the oral cavity. In front, it has a horizontal slit, which is, of course, the mouth opening. In any case, this provides the outer framework for the boundary of the dental arches. Okay, let's continue. In this layer, we see the depressor labii inferioris again, which we mentioned earlier, and the levator anguli oris muscle, but still somewhat covered by the other muscles. And further medial of it, the levator labii superioris, from lateral also, still somewhat covered. And now we come again to the parotid gland. In the anterior view, we see it's still located lateral to the masseter muscle, and now nicely exposed, we can see how the parotid duct passes through the buccinator muscle. In the anterior view, the buccal fat pad is now also visible. This is also known as Bicard's buccal fat pad. Dr. Bicard was a French pathologist during the time of the French Revolution in the 18th century. This buccal fat pad lies between the masseter and the buccinator muscle and fills the muscle frame groove to varying degrees, but depending on its size in the individual. It may also extend into the temporal fossa. Some people find it attractive to have this buccinator fat pad surgically removed. Such sunken cheeks are strangely enough a desirable ideal of beauty. Not only nowadays, it was already in the 30s of the last century when a well-known German actress of the time, I will not tell her name, had already undergone exactly this operation in Berlin. The question is whether such an operation can be medically indicated. Now we come to the temporomandibular joint region. only from the outside. As I said in the beginning, there is a whole own detailed lecture on the temporomandibular joint. Here we see the joint capsule and the lateral ligament, which as it runs obliquely slightly in front of the joint capsule. The question is whether you can always show this ligament so beautifully in the dissection course at the cadaver. However, it is always included in the textbooks, and it's supposed to ensure that the initial rotation of the mandible results in a sliding movement of the mandible forward when the ligament becomes tightened. We have now gone one step deeper in the preparation, and first of all we meet old acquaintances here again. The occipitofrontalis muscle with its anterior belly, the gallia aponeurotica and the posterior belly. And also the procerus muscle is still here. But in this layer the superficial fascia is now removed. In the uppermost layer the auricularis muscle with its other three parts has spread out on this fascia. But now this muscle and the superficial temporal fascia have been removed, and the temporalis muscle has become visible. This is also covered by another fascia, the deep temporal fascia. And the masseter is now also freed from its tough fascia. So here is the temporalis muscle, and its fibers run in a fan-shaped pattern laterally on the skull, and depending on the volume of the muscle you can see the temporal fossa in the skull. This is the shallow pit that the muscle has created later on the skull. We still left the buccinator muscle in this preparation layer, but now that the muscles for smiling have been removed, we can see the entire cause of the levator labii superioris muscle and the levator anguli which is still partly covered by the previous one. And the depressor labii inferioris muscle is now fully visible. Now you can also see its origin on the mandible and how it pulls toward the lower lip. The mentalis muscle has, I think, a peculiar course. It originates at the bony chin and then pulls on the inside of the skin to the chin. And what does it do? It contracts and curls the skin. For the last time in this preparation layer we see here the orbicularis oris muscle with the peripheral muscles radiating into it. So, and now we have reached the even deeper preparation layer. Now here the temporalis muscle is exposed, and because the masseter muscle has been partially removed, we can now finally see how the temporalis muscle attaches to the coronoid process. In doing so, it passes under the zygomatic arch, and here you can easily recognize this situation. This is the rest of the masseter muscle that we have left standing. And because most of the masseter muscle has been removed, we can now also see the buccinator muscle disappearing medially and posteriorly behind the mandible. And here, still show it for orientation, the parotid duct. Now that the masseter muscle on the left side is completely removed, the extension of the buccal fat pad becomes visible once again. And for the first time, we can now also see the complete extension of the area of origin of the levator anguli oris muscle from the maxilla. The orbicularis muscle is now almost completely free of all the oblique muscles that we have discussed before, and the mentalis muscle is now also freely visible. Now we can once again direct our attention to the forehead region. The occipitofrontalis muscle has been removed and the corrugator supercilii muscle is now visible for the first time. It runs somewhat further laterally than the procerus muscle, which of course is also still in the picture here. We already know that it can pull both eyebrows together, which leads to this vertical notch at the root of the nose. And the corrugator supercilii corresponds more to the course of the eyebrows, and therefore it can pull together each eyebrow for itself. In this preparation layer, the temporalis muscle is now exposed to such an extent that the radiation of the fibers under the zygomatic arch into the coronoid process can be seen very nicely. And in anatomy, it is customary, almost obsessively, to name everything you see, even if you already know it. So here the buccinator, the parotid duct, the orbicularis oris muscle, and the mentalis muscle. But this should be new here for you. Here we have projected on the skull all the areas of origin of the muscles of the face. You will certainly recognize the extension of the temporalis muscle in the temporal fossa and the area of origin of the masseter muscle on the ascending branch of the mandible. As far as the other muscle attachments are concerned, there is probably no point in going through all this individually in this lecture. It is more useful for you if you sit down calmly with a cup of tea or the like and go through it slowly in order to be able to memorize it. I don't want to go through the arterial blood supply in the face branch by branch with all the names in the context of this lecture either, but instead I would like to give you an overview from which you can continue at your leisure. Let us start with the neck. There runs the common carotid artery, shown in gray, which branches into the external carotid artery, shown in red, and into the internal carotid artery, shown here for once in blue. So let's stay with the external carotid artery for now. It runs behind the ear, up to the side of the skull, where it is called the superficial temporal artery. Before that, the maxillary artery branches off from it, which I will talk about in a minute. But first, the facial artery, which still branches off from the external carotid artery at the level of the lower jaw, and which gives off smaller branches to the lower lip and to the upper lip. And next to the nose it continues, now called the angular artery. And next to the nose and below the eye, it enters the anastomosis with vessels coming from the infraorbital foramen and also from the supraorbital foramen. And now it gets interesting. From the infraorbital foramen comes the infraorbital artery, which I have not labeled here, but it is drawn in red. It is one of the many outlets from the maxillary artery. And on top of the forehead there are blue-colored arteries, such as the supratrochlear artery. And the blue color here is just to show that these are branches from the internal carotid artery. This extends much further through the base of the skull and to the meningeal membranes, but there are also branches that go through the orbit back to the facial region. And the forehead is therefore supplied by blood vessels from the external carotid artery and also by such branches coming from the internal carotid artery, which again draw outward to the face. Details to this complex arrangement, I must say, please sit down and read. It is too complicated to be explained here in this lecture. And similar, yet different, is the venous outflow. The external jugular vein collects blood from the superficial occipital head regions, and it lies on the top of the sternocleidomastoid muscle. And the internal jugular vein lies further inward under the sternocleidomastoid muscle and receives the blood from the interior of the skull, but also from the face, which comes from the supratrochlear vein and the facial vein and the retromandibular vein and the submental vein, and also from the parietal ramus. Again, details please read up thoroughly. And the lymphatic drainage is shown in yellow in this picture. This is highly variable, but essentially follows the course of the veins. And the external jugular vein then flows into the subclavian vein, or sometimes into the internal jugular vein. And the internal jugular vein joins the subclavian vein to form the brachiocephalic vein, and from there it goes to the superior vena cava. You should not get frightened when you see the tangle of all arteries, veins and nerves of the face in the left picture. One day you will really know them all with their names, their course and their function. And on the right, all the muscles are added. So here you can see how the vessels and nerves intersect and the muscles in some places, how they are partially hidden by the muscles. In the following, I will give you a first overview of the two largest nerves in the face, the trigeminal nerve and the facial nerve. At the head there are the 12 cranial nerves, which you have to learn by heart sometime. In this scheme, I would like to discuss here only the spread of the trigeminal nerve, which is the 5th cranial nerve. It is called trigeminal because it has 3 main branches. The ophthalmic nerve, whose branches are shown here in the diagram in very light green on the forehead, and then the maxillary nerve, whose branches are shown in medium green in the middle of the face, and the mandibular nerve, which can be seen in dark green. This trigeminal nerve is mainly a sensory nerve, but it also has motor fibers with it, which supply motion impulses to the masticatory muscles. And otherwise, the facial nerve is the motor nerve for the muscles of the facial expression, you know that. Where the nuclei of origin of the trigeminal nerve are located in the brain, I have to refer you to the general anatomy again. It would be too much if I told you here. Well, only this much. There is the trigeminal ganglion, of course in pairs, on the right and one on the left side at the pyramid of the petrous bone, and then the 3 main branches of the trigeminal nerve just discussed branch off from it. The mandibular nerve is then accompanied by the motor portion of the nerve and passes through the oval foramen through the skull, to the skull base, and then runs mainly to the mandible. But you see that in the drawing, another, also large branch goes to the temporal region, which is the auriculotemporal nerve, and the smaller one is the deep temporal nerve. But the other part then enters the mandible on its inner side into the mandibular canal, and from there the mandibular nerve is then called the inferior alveolar nerve. From there, small branches go to the teeth and to the gums, and then it comes out of the bone again at the mental foramen, and it is then called the mental nerve. There it supplies the chin region. Before it enters the canal in the lower jaw, however, the lingual nerve branches off to the tongue and other branches to the masticatory muscles, for example, to the buccinator and masseter muscles. The maxillary nerve, the second nerve of the trigeminal nerve, goes to the upper jaw and comes out again through the infraorbital foramen in front and branches to the upper lip. It's called the upper labial branches. To the cheek and to the nose, here the external nasal branch is marked, and above the eye, the supraorbital nerve comes out and distributes to the forehead, and this has its origin from the first branch of the trigeminal nerve, the ophthalmic nerve. Innervation is complicated. It doesn't all fit into this lecture. I can only make the door a crack wide open for you and encourage you to read it up all in detail. Of course, this is important and very helpful for the patient if you really know your stuff. Now, no longer a diagram, but a real anatomy again. Here you see the facial nerve. This is the cranial nerve number 7. This is the nerve that innervates the muscles of facial expression motorically, but it also contains parasympathetic parts and sensory fibers. This also controls the salivary glands and conducts taste from the tongue. So again, you will have to read up all the details at your own leisure. The nerve comes through the stylomastoid foramen, through the skull base, and in the picture you can see how it comes out in front of the ear and branches out flat and wide across the face. Again, up to the temple, there are superficial muscles also, as we have seen, and then over the whole face, cheek, forehead, lower jaw. And by the way, it also passes through the parotid gland, which is not so good if there is a need for surgical intervention on the gland for some reason. And if the facial nerve is injured, the facial expression will be inevitably damaged. I advise you to get a study skeleton for studying the skull, at least the head. like this one. They are only available in plastic now, but anyway, there are good models that you can even take apart, like this one. If you have had that in your hand, then you can really understand it better once you have touched it with your hands. These images will help you to do that. We have artificially separated the bones into colors. There are, depending on whether you count the 3 auditory ossicles, 33 individual bones on the face. Some are paired, some others are not. Take your time to count them all and see if it's correct. Here are the individual names written on the bones, but I think I should not bore you with listing them all up. You will learn better if you pause the video here now or if you read the book at your leisure. And here is an unusual view from the back. Lower jaw, rows of teeth, and then you can look out at the front where it's light, right through the nose. And depending on what you will later do professionally, knowledge of the skull is important. In oral surgery and in orthodontics and craniofacial orthopedics, you will have to deal with radiographic images. Either here this kind of 2-dimensional lateral head film for cephalometry of the skull, which is taken in a standardized way to measure in a standardized way all the angles and everything, or we have been doing more and more for a few years, we take 3-dimensional radiographs, which of course show more. And this technique is called cone beam tomography, and the radiation exposure is somewhat higher, which must be strictly taken into account in the indication. But once you have such data, you can virtually cut through the volume and examine it in detail. Here the skull in rotation. Or here we have made the nasal airway visible also. Or here is an example of how you can generate a classic panoramic layer from the volume, or view individual slices through each tooth with the bone around it. Or as here, the temporomandibular joint region. However, the articulate disc, the muscles and the capsule and the connective tissue cannot be seen with this technique. This is better done with the magnetic resonance imaging. Here you can take a look inside my own skull. And depending on the representation of the proton density weighting, the soft tissues can be assessed particularly well for whatever image you want to have. And for imaging of the temporomandibular joints, there are special coils that image the temporomandibular joint better, and you will see this in more detail in the lecture on the temporomandibular joint later. So now we come to the take-home message after this long introduction to the anatomy of the face. We talked about the regions of the face, looked at details of the facial skin, and also mentioned something about aging, intrinsic and extrinsic aging. And then we went more into depth. In the face, the fat is typically but individually arranged in different amounts. And the same goes for the muscles, which we looked at in detail also. And in principle, they are the same in everybody, but they can of course vary in size and thickness, and actually also in training condition. I have also roughly touched on the vascular and nerve supply as well as the cranial bones. And here you will have to study further at your leisure. And after all, a lecture like this is only meant as a door opener. And I've given you some clinical notes as a hook as to why this is really all important, basic knowledge. We went through the topographical anatomy layer by layer right at the beginning as a 60 seconds film. You can watch it again. It's also available individually on Instagram and on Facebook. And with that, I thank you for your kind attention.